Welcome to today's Ethnic Media Services Zoom News Conference. I'm Sandy Close, Director of EMS. Today, our topic is the topic that launched our Zoom initiatives back in March of 2020, COVID-19. Where are we almost 3 years later? Is the pandemic over? Are we in the late stage pandemic? What should we expect in the year ahead? A new subvariant of Omicron named XBB 1.5 now accounts for 40% of COVID-19 infections in the United States. XBB 1.5 is even more prevalent on the East Coast, accounting for 75% of infections. Speakers will brief us on the origins of the new subvariant, the challenges it poses for our current vaccines, including the updated boosters, new therapeutics in the pipeline, and what will happen when the public health emergency ends and testing, vaccines, and treatments like Paxlovid are no longer for free or at subsidized rates. Researchers will also discuss a new study of the positive impact of vaccinations on California's prison population. Our speakers include Dr. Ben Newman, Chief Virologist of the Global Health Research Complex, Texas A&M, Dr. Oliver Brooks, Chief Medical Officer, Watts Healthcare in Los Angeles, Jill Rosenthal, Director of Public Health Policy at the Center for American Progress, and Sophia Tan, Research Data Scientist at UC San Francisco Medical School. And now I turn the microphone over to Sunita Sarabji, Health Editor at EMS, who will moderate today's briefing. Thank you, Sunita.
Thank you, Sandy, and welcome to all our speakers and reporters on this first briefing of the new year. We start off with Dr. Ben Newman, a familiar face to people who have attended our previous briefings. Welcome, Dr. Newman.
Thank you. Okay.
Dr. Newman will provide an overview of the subvariant and how we got here. Welcome.
I'll do my best. When speaking about COVID, I think it is important to remember that COVID was the third leading cause of death in 2020, the third leading cause of death in 2021, and also the third leading cause of death in 2022. So anyone who's telling you that COVID is over is, I don't know, misinformed at the very least. For those tracking other diseases, influenza peaked about 5 weeks ago and has been coming down. That's good news. Respiratory syncytial virus, or RSV, peaked 8 weeks ago and has been coming down steadily. That is also good news. However, COVID cases are rising, driven by XBB 1.5 and some other variants, but mostly that one. So XBB 1.5 appears to grow well and have a little bit better affinity for the receptors in our lungs. It is better at holding on to people, essentially, than some of the previous strains it evolved from. It has many changes in the receptor binding domain. This is the part that actually makes contact between the virus and the human. And it has 12 changes in this region compared to the original virus, and 5 mutations in this region compared to BA5, which is currently used as the other half of the bivalent vaccine, along with the original version. To put that in perspective, when Omicron first appeared and started cutting through immunity, it had 7 or 8 mutations in that region compared to the strains that were circulating at the time. So XBB represents nearly, but not quite, as large an evolutionary step as Omicron. And based on the rapid rise, it would appear that it is living up to its genetic destiny. It appears that it is very infectious and is overcoming at least some components of immunity. There are multiple problems, I think, in dealing with XBB 1.5. One of those is the low vaccination rate, which is entirely voluntary and currently sits for the US at about 15% of the total population. The new bivalent vaccine has been approved even for people under 5 years old, the Pfizer version, but uptake has not been very high lately. The other problem, and some of the references I put into the chat at the beginning, the other problem is that the current bivalent vaccine provides some protection, but not very good protection, particularly against XBB. Those studies were done with XBB1. XBB 1.5 is a little bit different, but not at the key receptor binding domain. So those should be representative. But as the authors of that paper concluded, and the authors of several other papers concluded, it is definitely time to update the vaccine strain. Unfortunately, the FDA Vaccines Advisory Committee has not met in 3 months. It has not met to discuss COVID-19 specifically in 7 months. The World Health Organization committee that chooses vaccine strains and makes recommendations has not announced anything in the past 7 months. And the World Health Organization has not made an announcement on XBB in the past 2 months, when it was a very different situation. So I think collectively at the individual level and also at some administrative levels, we've essentially taken our eye off the ball as refers to COVID-19.
We need to move on to Dr. Brooks. Dr. Brooks, welcome. Dr. Brooks will address the importance of continuing vaccines, getting the vaccine and getting treated, even as we address this new subvariant. Welcome, Dr. Brooks.
All right, thank you. Thank you for having me and having this press conference. I want to go back to a question I think that was really relevant, which is one of those that was asked to Dr. Newman. Is it or will it be endemic? So what does endemic really mean? Endemic means an infection that is still circulating in an area or community, but is not disrupting daily life. So, I mean, I thought about endemic, colds are endemic, car accidents are endemic, not infectious, of course. But is it disrupting our daily life? So I would say right now, yes. But can we move to where it is not disrupting our daily life? And that's so Dr. Newman kind of addressed that, what kind of problem is it? So I think we can get there. So I use that as a lead into what can we do to get it to endemic, which means not interrupting our daily lives. I don't believe COVID is going away, just like influenza or RSV. Those are both theoretically endemic. They come higher in the winter seasons. Which is what a lot of respiratory viruses tend to do. So testing, vaccinating, and treating. That's basically the tools in our armamentarium. Obviously, the science to get to that. And I also want to note, Dr. Newman, that the VRBAC, the FDA Virus and Related Biological Products Advisory Committee, is meeting January 26th, which is in about 3 weeks. And they will be discussing it. So I do not feel that we have dropped the ball. There's just so much going on. So that will be happening soon. Testing. So there was a question in the chat box about did this come from lack of vaccination? So what happens is variants come around when the virus is spreading more rapidly. If it's not spreading more rapidly, because more people are vaccinated, then you are less likely to get real variants. And what real variants mean, the ones that will grow in number. The only reason that XBB 1.5 is growing in number is because it can evade the immune system, and it is somewhat more impervious to vaccines. So it is crucial that you get tested, because when you get tested, you go into isolation. That still has not changed, and someone else will address it, but you theoretically get treated. So we do need to keep testing. Our plan will be anyone coming in, people coming into my house and I have back pain. Oh, by the way, I have cough and runny nose. Okay, so in the winter, on this call right now, 1 out of 3 of you all have URI symptoms. So we're going to test everyone with URI symptoms. If you have, you test positive for COVID with the rapid test, then we'll take care of you. If you don't have it, then go on inside and get your back pain treated. So testing is still crucially important. It is great that there are rapid tests. As a pediatrician, I love this calling. Yeah, my 7-year-old has a cough and runny nose. So has he been around anyone? Oh, no, I tested him. I am so impressed that my mothers are testing their children without me telling them to do it. So that's one of the great successes. Vaccination. So Dr. Newman spoke accurately. The present bivalent vaccine is the ancestral strain from Wuhan, coupled with the BA.4/5. The data showed that it did get immune response to the BA.2 subvariant or variant. However, let me add, XBB comes off of BA.2. It's a little tricky. We got BA.4.5 vaccine in the bivalent. It does give some response to BA.2, but not a good response, and not a very good response against XBB. So then what do? Okay, he also made an excellent point, which is the crucial one to me, is that only 15% of the population has had their second booster. So people need to get their second booster. I think the concepts of how well it responds and the new variant are all well and good. However, the vaccine is safe and effective, and there's no reason not to get vaccinated. If the vaccine had a 10% response rate, you still get vaccinated. There's a 90% response rate in terms of the immune response against the vaccine, against the virus, you get vaccinated. I just want to be very, very clear about that fundamental concept. Probably, by the time some of you get vaccinated, you get it in, there may be another variant. XBB made it strong because it evaded the immune system. It wasn't killed as well by the vaccine, and it came in like October. So it came right then to go around. Who knows what's going to happen in the spring? So the next variant may be more susceptible to getting vaccinated.
Thank you so much for your comments, Dr. Brooks. We next welcome Jill Rosenthal from the Center for American Progress, who will talk about the cost of Paxlovid once the public health emergency ends, and also the end of free COVID testing and treatment. Jill, welcome.
Thanks so much. Fascinating conversation. I think I have some things to say that build on what we've heard so far. Hope not to repeat, but I think, starting with the fact that as we've heard and we know, COVID is not predictable. And as we've already heard from Dr. Newman, we are in a winter surge. And this is at the same time that we are unwinding federal payment for COVID vaccines, tests, and treatments. So although we may like to imagine that the pandemic is over, it is absolutely not. As we're shifting to this commercialization response, we're preparing to end continuous coverage protection for people on Medicaid. And so at the same time, we have the depletion of federal supply and resources, and we have the end of the public health emergency coming, and we have the end of continuous eligibility for Medicaid. So, this can make access challenges even greater. And I think that this really raises access and also equity concerns. We had mostly closed the gap in vaccine disparities, but The data from November shows that the rate of white people who have received the bivalent booster was twice that of those of eligible Black and Hispanic people, and nearly twice as high for Native Hawaiian and other Pacific Islander people. We also could see in October that vaccinated, in hearing what we've been talking about, the fact that the vaccine may become less effective, but we also know that in October, people who had been vaccinated with the fall booster had more than 18 times lower risk of dying from COVID than people who were unvaccinated. And they also had a 3 times lower risk of infection. So although we have these challenges with the new variants, I just want to echo what Dr. Brooks is saying and how critically important it is that people get vaccinated. It's the number one thing that we can do to protect ourselves. It's already been mentioned, racial and ethnic gaps in terms of treatment of Paxlovid. There's data that also shows rates of self-reported long COVID are more common among people who are female, transgender, Hispanic, and those without a high school degree. There's some studies that suggest that Latino and Black adults who have had higher rates of workplace exposure to COVID have had higher rates of COVID and then eventually long COVID. So there's some indications that, again, disproportionate impact on vulnerable communities. So just to add that even if we had a smooth transition to commercialize the COVID response and make vaccines, tests, and treatments available, we still need public funding because we need to continue to basically, do the research needed for, as Dr. Newman was saying, updated vaccines. We need to be able to fund that kind of research to develop new vaccines. And we need to make sure that our private sector partners are producing the tests that we need. We may remember that there were long lines at one point to get tests, which was because at one point, Abbott Laboratories was destroying tests because it looked like we didn't need them anymore. And then we were left without them. So we need to make sure we are preparing and stockpiling what we need for the future. Not to mention the fact that we need to continue to track the disease. So we know, prevalence rates. We need to continue to support research into long COVID, and we need to continue to support global vaccination efforts because as we know, these things travel. So in terms of what we can do, I'm a little pessimistic. I don't see anything happening in Congress in the near future. I will say that the federal government is pursuing public-private partnerships. There was just some recent information about a meeting to discuss new monoclonal antibody treatments. That was a public-private partnership. I know the government is saying that they're intending to work with their industry partners to provide access to vaccines. We don't really know what that means at this point. There is some interest in a vaccine for adults program. Right now, there's a vaccines for children program so that children on Medicaid or uninsured children can get access to vaccines, and there's some interest in creating a program like that. That would be a vaccine for adults program. Again, that may depend on what we see happen at the federal level. And then there are some things that states can do. So in the new budget that just passed, the federal budget allows states to start disenrolling people from Medicaid at the end of the first quarter of 2023. And so when that happens, people can lose their Medicaid coverage, which, as I had said earlier, provides access to vaccines. So in terms of what states can do about that, they can look at ways to keep people who are going to lose Medicaid eligibility insured. So I'll just give you a few examples of things I've heard. And again, it's very early on this, but there are states looking at ways to simplify enrollment processes and to promote continuity of coverage for people who may lose Medicaid coverage. So for instance, some states are looking at ways that they can automatically enroll people who are going to lose Medicaid coverage into marketplace plans. So California and Rhode Island are doing that right now. They're looking at ways to automatically enroll people into the lowest cost marketplace plans so that when they lose Medicaid coverage, they still have some coverage, and then they can opt to keep it or not. Another example is in Oregon, where they've developed a bridge health program, which will allow existing Medicaid members who earn a certain percent of the federal poverty level to stay enrolled in Medicaid temporarily. And so, I think this is something we're going to need to watch, because it's obviously, as I've said, very concerning not to have federal commitment to continue to respond to the pandemic, because again, we don't know where it's going. One other thing I do just want to mention is to add on to what Dr. Brooks was saying about vaccines, tests, treatments. The other things we can do are things such as improving our ventilation and air filtration. And so this is important for all respiratory illnesses. And there has been federal money coming to states and communities that can be used, for instance, in schools, so that, we can make sure we can keep our schools open and make sure we can keep people safe, or at least make it less likely that diseases spread.
Absolutely. Well, thank you, Ms. Rosenthal. We'll move on to our last speaker, Sophia Tan, who will discuss her novel research into the prison population and vaccine efficiency and the rates of infection and reinfection in the prison population. Sophia, welcome.
So, hi, everyone. I'm Sophia Tan. I'm here to share a little bit about our study that was recently published in Nature Medicine on the infectiousness of SARS-CoV-2 breakthrough infections and reinfections during the Omicron wave. So with the rise of these more contagious variants like Omicron that everyone has been talking about today, there have been more frequent cases in a few different groups of people. So this includes, we see a lot more breakthrough infections, which are infections that we see in people that have been vaccinated for COVID-19. There are more cases among people that have had previous infection. So these are reinfections. There are also cases in people that have had both prior COVID-19 vaccination and prior infection. I'm going to share a little bit more about some of the results. So we found that any vaccination, so any number of doses, any type of vaccine, was associated with a 22% reduction in your infectiousness. And residents that had prior infection, any prior SARS-CoV-2 SARS-CoV-2 infection, then experienced 23% reductions in their infectiousness. And we also saw that there was an additive benefit. So there are residents that have had both prior vaccination and prior infection, and we saw that these residents had 40% reductions in their infectiousness. This really supports that there is additional benefit from getting vaccinated even after you've had prior infection, and that there's this additive benefit between these kinds of exposures. And so I talked a little bit about the vaccination status in terms of reducing infectiousness, but we also broke this down a little bit more. Of course, we know that vaccination is based on the number of doses that you receive, and there's also this waning effect of vaccine effectiveness. So we first broke down vaccination by the number of doses, and we saw that each vaccine dose has an additional 11% reduction of infectiousness. And in terms of time, since your most recent vaccination, your infectiousness actually increases by 6% every 5 weeks after your most recent vaccination. And so this, of course, is a lot of benefit and a lot of evidence for more recent vaccination and getting additional doses of boosters and additional doses of vaccines. So some of the key takeaways from this study are that COVID-19 vaccination and prior SARS-CoV-2 infection reduce the infectiousness of Omicron infections. And we also see that there's added benefit. So having vaccination, even though you've had prior infection, will further reduce your infectiousness if you happen to then contract an Omicron infection. And we also saw that there's additional benefits from having additional doses of vaccine and also having more recent vaccination. But of course, even though vaccination and prior infection reduce your infectiousness, risk of transmission of SARS-CoV-2 is still really high in the general population, and especially in this incarcerated population that we studied. This means that COVID-19 vaccination and infection reduce your infectiousness, but do not completely stop transmission. Some of the most exciting parts about this work are the policy implications for various different vaccination interventions and the evidence it really provides for the benefits, the hidden benefits of vaccination. So not only do vaccines ideally protect you from getting infected, but if you do get infected, we see that there's this hidden benefit that they are preventing and reducing the risk of you transmitting disease to other people. Some of the other policy implications for the general population, including the incarcerated population, include mass and timed vaccination, since we see this benefit from additional and more recent vaccination, especially in relation to these new surges that we see periodically. And specifically for the incarcerated population, we hope that this work really highlights how at risk the incarcerated population still is, and that there is much more that we can be doing to boost vaccination among both incarcerated people as well as the prison staff that they are surrounded by, targeting a lot of different vaccination interventions towards staff members, including boosting their vaccination rates, which are much lower than the incarcerated population, as well as boosting the rates of making sure that prison staff are staying up to date with their vaccination and with the recommendations from the CDC and other health organizations is really important for also preventing transmission.
Thank you. Sandy, any closing remarks?
I believe you got so much packed in. You four presenters were extremely illuminating in a very murky kind of picture for us as we open 2023. Thank you for illuminating.